Welcome to The Explainer. Today, we're going on a journey, a really important one, to understand what it's like to face one of the toughest diagnoses out there, pancreatic cancer.
And to really get it, we have to start with the big question that looms over this whole topic. Why do we always hear pancreatic cancer called a silent threat?
Well, the answer is right here, and it's pretty sobering. It's all about timing. For a huge majority, a full 80%, of tumors found in the most common spot, the head of the pancreas, it's already too late for surgery by the time they're discovered. The cancer just grows quietly, without ringing any alarm bells, until it's already got a serious head start.
So let's start there. Let's really dig into what makes this cancer such a formidable foe. And it's not just about the symptoms it causes. It's maybe even more about the ones it doesn't.
With pancreatic cancer, location is everything. It literally determines your destiny. If the tumor's growing in the head of the pancreas, it can actually block the bile duct. Now that causes a really obvious sign, painless jaundice, where your skin turns yellow. And that can be a crucial, if strange, lucky break, because it leads to a much earlier diagnosis. But if the cancer's in the body or the tail, the first signs are usually just vague pain and weight loss. They show up so much later, and that, unfortunately, often means a poorer prognosis.
But these subtle symptoms and late discoveries, that's only part of the story. To really see the whole picture, we've got to look deeper, way deeper, right into our genetic blueprint to see what risk factors might be setting the stage.
Okay, so we do know that some things in our life and health can raise the risk. Stuff like smoking, long-term inflammation of the pancreas, diabetes, obesity, all of these can help create an environment where cancer is more likely to take hold.
But the real origin story, where it all begins, happens at the genetic level. And this quote just nails it. For almost every single case, 95% of them, the whole terrible process kicks off with one tiny genetic typo, a mutation in a gene called KRAS. It really is the first domino to fall.
And while that KRAS mutation is the most common spark, some rare genetic conditions, they're like pouring gasoline on the fire. For someone with a condition like Palliot's-Jigger syndrome, their lifetime risk of getting this cancer can be amplified by a staggering 100 times.
So you've got this tough combination of subtle symptoms and these hidden genetic risks. How in the world do doctors start the detective work to figure out what's really going on?
A lot of the time, that detective work starts with a simple physical exam. There's this principle called Courvoisier's law. It's from way back in the 19th century, but it's still a huge clue for doctors today. Basically, it says that if a patient has jaundice and their gallbladder feels swollen, it's probably not a gallstone. It points the finger of suspicion toward a tumor causing that blockage.
But to get the real story, doctors need to see inside. And the absolute gold standard is a very specific kind of CT scan. It uses a contrast dye and a special pancreatic protocol, which means the machine takes incredibly thin slices, just 2 or 3 millimeters thick. This gives them a super detailed map of the pancreas, which is just crucial for both diagnosis and planning what to do next.
And when they look at those scans, this is one of the classic signs they're looking for. It's called the double duct sign. Just imagine 2 major highways that are supposed to merge, but there's a big roadblock right at the intersection. That's exactly what's happening here. You can see that both the bile duct and the pancreatic duct are swollen up because a tumor is blocking them right where they meet. It's a flashing red light that something is seriously wrong.
All right, so once the cancer is confirmed, the next huge step in this journey is to stage the battle. You have to figure out exactly how far the disease has spread to come up with a precise plan of attack.
At this point, there is one question that trumps all others. Can we surgically remove this tumor? And the answer comes down to its relationship with the major blood vessels that are crowded right around the pancreas. If the tumor is clear of them, it's called resectable. If it's just touching some of the major veins, it's borderline. But if it has wrapped itself around major arteries, or if it has already metastasized and spread to other parts of the body, well then surgery is just not an option.
And that brings us to the treatment itself, the fight for the future, what the road ahead looks like for patients, whether surgery is on the table or not.
For patients who do have resectable tumors in the head of the pancreas, the main weapon in the arsenal is an incredibly complex operation called the Whipple procedure. Make no mistake, this is one of the biggest, most demanding operations in all of surgery.
And when I say it's a massive undertaking, I mean it. Surgeons have to go in and remove the head of the pancreas, the gallbladder, the first part of the small intestine, and sometimes a piece of the stomach too. But believe it or not, taking all that out is only half the job. Then, they have to meticulously reconstruct the entire digestive system. It's like a masterclass in plumbing to make sure the patient can eventually eat and digest food again. It is truly incredible.
But for all those patients where surgery isn't possible, the fight is far from over. It just shifts gears. The focus becomes systemic treatments, ones that travel through the whole body. Chemotherapy, with a drug called gemcitabine often serving as the cornerstone, becomes the new weapon to try to control the cancer, manage symptoms, and buy more time.
And so, that brings our journey full circle, leaving us with one last big question. We started this whole thing with genetics, right? Learning that one KRAS mutation is the first step in nearly every single case. So you have to wonder, does the future of fighting this disease lie not in bigger surgeries or stronger chemo, but in finally cracking the code to fix that one single initial typo?